How then does this translate into patient encounters, and when and how can nurses intervene? Nurses can turn the tide in COVID-19 and other disparities when we fight against our own biases and hold others accountable for theirs. Let's see what this looks like in a case study. Jonathan is a 45-year-old African-American man. He called out of work because he wasn't feeling well. His temperature was 100 degrees. He had a slight dry cough and was constantly fatigued. With all of the news about coronavirus, his wife wanted him to go get tested. But Jonathan didn't feel like going through the hassle because of an incident that occurred at his last appointment. His cholesterol was slightly elevated, and in response, his provider told him to lay off of the fried foods, assuming that's what he ate, but not knowing that Jonathan did not fry food in his household or eat it when dining out. As we're going to look at different points where nurses can intervene, we come to our first one, which is that we should never assume someone's health, dietary, or other practices based on their race or any other factors. We can ask relevant questions instead of defaulting to harmful racial or other heuristics. That helps us avoid such microaggressions and dehumanization as Jonathan experienced in this incident. When we reflect on this encounter and the countless others that came before it, we can see that these things are shaping Jonathan's disposition toward the healthcare system. And ultimately, they will contribute to his delays in seeking care. And when we understand that, it gives us insight to be more gracious and understanding when people who have experiences similar to his present for care later with symptoms that are more dire and more complex. Through the night, his fever fluctuated between 100 and 103 degrees. His wife convinced him to go to the urgent care center when his cough worsened and he had trouble breathing. Upon arrival, he noticed that the staff was overwhelmed by the volume of cases. Jonathan requested to be tested for COVID-19, but was told that he did not meet the criteria and wouldn't be at risk anyway. He was diagnosed with bronchitis, given prescriptions for albuterol and azithromycin, and sent home. In this encounter, the provider assumed that Jonathan had not traveled outside of the country, possibly because their own implicit bias presumed that he did not have the financial means to do so, or that he would not be interested. And even when Jonathan attempted to explain his risk, the provider was adamant that it was just bronchitis and he had nothing to worry about. We should never assume that someone is or is not at risk for health issues based on their race or our other preconceived notions about them. We must challenge colleagues when they do this as well. We also don't want to let what we think is going on with the patient cloud our judgment from doing and even advocating for a complete and thorough workup. In this particular encounter, Jonathan was frustrated because just like his last experience, he was not being listened to. And so as a result, he didn't fully disclose his potential exposure. He had not traveled, but his in-laws recently returned from Venice about 2 weeks before his symptoms developed. They only had slight colds, however, and weren't having any symptoms as severe as what Jonathan experienced. Another thing that we want to be mindful of as nurses, many of our patients are not healthcare professionals. And so Jonathan, not being in healthcare, when he comes to our system, he assumes that we as the provider know best. And so he'll start the treatments that we recommend. We're a trusted profession who the public looks to steer them in the right direction for their health, not for our biases or other factors to determine the course of action. About 5 days later, Jonathan's cough became so severe he could not catch his breath. His wife tried calling his primary care provider and multiple urgent care centers for advice because the bronchitis treatment was not working and her husband was getting worse. Despite pleading for him to be tested, she was repeatedly told that he did not need COVID-19 testing and that she should simply wait for the Z-Pak to improve his symptoms. Late one evening, she noticed a slight darkening to the color of his lips as he gasped for air. She called 911. He was rushed to the emergency room, and she stayed behind, not knowing whether she would ever get to see her husband again. Upon examination in the ER, it was discovered that Jonathan had pneumonia in both lungs. He coded and was ultimately intubated. One thing here, and this is the one that really I want to drive home for us as nurses, both Jonathan and his wife had concerns that they made clear and expressed, but were ignored and dismissed after multiple points of contact with the healthcare system. And this doesn't just happen with COVID-19. There are countless cases, even across health conditions, where racial and ethnic minority patients' symptoms are ignored and even minimized. And then as a result, they don't receive adequate care, diagnostic testing, treatment, other life-saving measures in time. And we really see this with inequitable maternal and infant mortality. As nurses, we can and should be the advocates to make sure that our patients' concerns are not only heard, but also taken seriously. And that should happen whether we're in contact with them by phone, in person, or other means. Jonathan was admitted to the ICU and subsequently tested positive for COVID-19. Over the course of a few days, one of his nurses noticed that treatments were not being made available to Jonathan that other patients were receiving. The nurse challenged the care team to consider all treatment options and provide comprehensive education for Jonathan's wife so that she was able to make an informed decision. He was started on plasma therapy, his vent settings were weaned, and he was eventually extubated and switched to proning with high-flow nasal cannulas. This one I get very excited about because despite the prior missteps, the actions of one ICU nurse, one individual, changed the course of this man's outcomes. This person stayed up to date on ever-changing guidelines for treatment, and they asked questions, which is especially important when you notice patterns in patients who are and are not receiving certain treatments. You have to take time to educate patients and their families, acknowledging potential fears or concerns they may have, particularly when we're looking at new or novel treatments and therapies. We want to be mindful of medical mistrust. People have reason for being skeptical about trying new treatments, and we can incorporate that and bond with them as we try to teach in those areas. And also, we can advocate for patients when we see that clinical decisions are not rooted in evidence, when there is implicit or explicit bias, racism, or discrimination that is driving our decisions that inevitably leads to poor health outcomes. So because of one nurse's care, Jonathan joined the 10% of survivors who make it off of the ventilator with COVID-19. While this is only one case study, whether future Jonathans live or die is partly in our hands as nurses. And for those where death is truly inevitable, we can better support patients and families in the process so that it is a dignified death. How does this apply to you as you watch this webinar? You can intervene within your sphere of influence. Wherever you find yourself in the beautiful landscape that is our nursing profession, there are things that you can do to bring about change, not just for COVID-19, but other health inequities as well. If you're in clinical practice, ensure that all patients are treated equitably, regardless of their race, ethnicity, or any other factor, and provide comprehensive patient education. For those in research, ask research questions that do not perpetuate disparities. So taking into account that when we're looking at race, it is not a biological or genetic thing that we're measuring, but rather that shared experience of oppression and other factors that's causing and contributing to what we're seeing. And similarly, when we analyze our data, we can look at between and within group differences, making sure that we factor in those important social determinants of health. For those in education, acknowledge healthcare system mistrust when you're talking to patients and their families. And also prepare future nurses to do the hard, difficult, arduous internal and external work of addressing racial disparities. For policy, we can create programs to address implicit bias, racism, and discrimination that most certainly exist in the nursing workforce, as well as implement structural interventions to address the social determinants of health. As we do this work, no matter where we find ourselves, let's remember there is no need to reinvent the wheel. From faith-based institutions to grassroots organizations, there are people in your areas who are already doing this work, and you can partner with them. Make it a point to find them, and remember they are the experts in their experiences and their communities. I celebrate and applaud those of you who are already doing something, and if you haven't already, you can work with others to help them take similar actions. Lastly, I encourage you to remember your why. Many of us chose to become nurses because we wanted to help people. We desired to save lives, provide support in the illness and death processes, and make a difference in the world. But health disparities are a direct threat to our ability to live out our passion. The good news, though, is that change begins with each of us. As one of the most trusted professions, we have both the platform and the power to bring an end to racial disparities in health, including those seen with the coronavirus, morbidity and mortality. Until this work is done, we will remain in a perpetual cycle of Black, Brown, and Indigenous communities disproportionately and unnecessarily suffering from many health challenges that come our way. People are scared, hurting, they're confused. As nurses, we can step in and step up. The statistics we see are not biologically or genetically driven. These disparities can and should be avoided and eliminated. So let's ensure that our practice, leadership, research, teaching, scholarship, and other nursing endeavors are rooted in strong evidence and critical thinking, not our own thoughts and biases. And we have some resources for those who are interested in learning more about your implicit biases or the ways that these biases affect outcomes in health. You can go to the links that are here on this slide for that information.